byproducts are carbon dioxide, carbon dioxide, water, and ATP, as you can see here. And with 1 mole of oxygen and glucose, we develop 38 moles of ATP. Now, in shock, we have inadequate delivery of oxygen and glucose to the cell. So instead of having aerobic respiration, we have anaerobic respiration, which is very inefficient. It only produces 2 moles of ATP as opposed to 38. And of course, we get lactic acidosis. And the treatment, of course, of shock is to restore blood flow and substrate delivery to the cells. I think I've shown this picture to you before, and I'm going to show it to you again because I think it's so useful, or it has been so useful in my life. At 3 o'clock in the morning, when you're exhausted, not thinking straight, and you got a patient who's hypotensive, and you can't figure out what's going on. So if you're in that kind of situation, just simplify the system in your mind. You've got a pump, you got a pipe, and you've got fluid in the pipe. And if you put a pressure gauge in your system and this pressure gauge is low, there's only 3 possible reasons why the pressure in the system could be low. One reason is the pump is broken. Pump is not working, right? The second reason is, for one reason or another, the diameter of the pipes has increased. And the third reason, probably the most common reason on the surgery services, that you got fluid leaking out of the pipes. Those are the only 3 reasons why the system can be low in the system, the pressure can be low in the system. So let's take that simple system that we just discussed and apply it to the human being. If you have a pump problem, that means you got a problem with your heart. And you could be in acute or chronic heart failure. You could have pericardial tamponade. You could have a pulmonary embolus, which is kind of like throwing a wrench in the pipe. You're blocking the outflow of the pump. Or you could have a tension pneumothorax. Now, tension pneumothorax has various effects on the heart, but it's not exactly on the heart. But generally, we throw tension pneumothorax into the category of pump problems. You can debate that, but let's say for the purposes of our discussion, we're going to put tension pneumothorax in with pump problems. So let me give you an unknown here. This is not one of the unknowns at the end of the case, but you have a 46-year-old woman who presents to the emergency room with abdominal pain. So the residents are down there and they see her. She doesn't look too bad. She's stable. They want to maybe get a CT scan, observe her, and they say put her in an observation ward. And a few hours later, the patient has a near cardiac arrest. Okay, so they resuscitate her, intubate her. She's profoundly hypotensive, has a distended abdomen. So the question is, what would you do? So let's say Anthony Paliango, do you want to answer that question? There's no wrong answer. Here you are in the emergency room. You got this patient had been sitting in the emergency room. Suddenly the pressure dropped. What are you gonna do here? He's got a distended abdomen, hypotensive, 6 hours and observation for abdominal pain. What do you want to do? All right, no answer. How about you, Edward?
Maybe Daniel Makerere.
Okay, well, Mugisha, why don't you answer the question just to move this discussion along? Well, how would you handle this problem?
All right. So number 1 is to find out what is really causing the patient problem while you are resuscitating with IV fluids to keep the pump, to keep the pipe with the fluids. Sorry.
Okay, so we got a blood pressure of 50 now. The abdomen is massively distended. and she's hypotensive. You're at home. You're getting all this information by telephone. What are you going to tell your residents to do?
They start large bore cannulas for resuscitation of bolus IV
Okay,
fluids.
we'll give them that they know how to, they know how to, we want to get beyond the, we'll give them that they know how to resuscitate the patient. They got fluids running, they're doing all the right things, but are we going to send the patient to the CT scan? We're going to send them for a plain film of the abdomen. We're going to go for an angiogram. Should we take the patient to the operating room? What should we do?
I think take a get the patient to operating room, must be bleeding somewhere within the intra-abdomen.
Okay, so I agreed with that. I told the patient, I told the residents, take the patient to the operating room. I'll meet you in the operating room. So I get to the operating room. The patient is profoundly hypotensive. The patient is prepped and draped. The abdomen is massively distended. So we decide to do an exploratory laparotomy, thinking that he must have a ruptured spleen or ruptured liver. Maybe somebody beat her up and we got the wrong history, whatever. So we open her up, and what we find is that the stomach is massively distended. And why is the stomach massively distended? Because during resuscitation, when they were doing bag mask ventilation before intubation, a lot of the air went into the stomach. So we decompress the stomach, and we find no blood in the abdomen, no blood in the retroperitoneum. All right, so we're thinking now it's 2 or 3 o'clock in the morning now, and here we're trying to figure out what's going on. There's no blood in the peritoneal cavity. There's no blood in the retroperitoneum. She didn't break a leg. There's no blood in the extremities. We put an NG tube down her and where we had already done that to decompress the stomach. There was no blood in the GI tract. I put a chest tube in each chest, small chest tube, to see if she was bleeding in the chest, which she wasn't. So now we're stuck there. And what do you think might be happening? Can Dr. Benson, can you answer that question? What would you do now? You're in the operating room. The belly's wide open. You've got you thought the patient was bleeding. That didn't happen. So what are you going to do now? Dr. Benson Harrison, can you answer that question? Mugisha, why don't you start calling on these people so we can get some participation? Anybody want to answer the question? Rukia? Guys, if you...
Chimwemwe wanted to answer. Go ahead,
Yeah,
Chimwemwe.
everybody, just let's get somebody to answer so we can have a discussion.
Hello, yes, in that case, I think since we have ruled out everything in there, that there's nothing in the abdomen going on also in the chest. I think it would be wise from the anesthesia side to think whether there's a problem within the heart itself. So we may start inotropes.
All right, so they start inotropes. What else do you want to do? Let's go back for a minute and look at the system. All right, you got a pump, you got pipes and fluid in the pipes. Why could the patient be septic and maybe have dilated vasodilatation?
Okay, Monga, what do you want to say? Monga, Bikunga.
No. I'm just following.
Okay.
We can't hear you. So I think we go ahead with.
Jim said that he thinks there might be a pump problem, so he wants to start inotropes. Okay.
Yeah, I think.
Yeah, go ahead. What do you think?
I think it's a fluid problem and it's a blood problem, so I'll start a transfusion.
You want to start a transfusion? Okay, so you start a transfusion. Pressure is still low.
Then there is a pump problem after that. When the pressure is too low.
How can you assess a pump problem? What pump problems might be occurring? Let's look at that. What pump problems might be occurring?
So there is on the chat box, someone is saying anesthesia drugs can cause vasodilatation. So you need to check with them.
Okay, right. So the patient could be. We'll get to that in a moment. I like that idea, but we didn't think that was happening. particularly spinal anesthesia can cause hypotension because of vasodilatation. You're right that there are various anesthetic drugs which can cause vasodilatation, but usually that can be corrected by fluid administration, and we're administering fluid and it wasn't corrected. Okay, anybody else have another idea?
Maybe the measuring machine is a problem. One is commenting from the chat box.
What was that? What was
Say
that comment?
the machine that is used to measure blood
Oh, I
pressure
love that idea. So
it's broken.
make
Change
sure that
another
the patient isn't hypoxic. So just hand ventilate the patient, make sure the patient's being ventilated. If you got a pulse oximeter on, that'll give you a lot of good information. If you have an end-tidal PCO2, if you have that available in your operating room, that'll tell you whether the patient's being ventilated or not. But if you have any question at all, what's happening, now also, nobody mentioned,
Someone has raised their hand, so we
Yeah,
allow
ahead.
him to make a comment. Go ahead, unmute
Go ahead.
yourself.
Who raised their hand?
Unmute yourself. Is
Infinix
Infinix
Smart 5, and unmute yourself. You're on mute. We can't hear you.
Yeah, he's not unmuted.
Okay, well, one of the, go ahead, Infinix Smart 5, go ahead. Who are you, Infinix Smart 5? All right, guys, one of the first things that happen intraoperatively, when you have an intraoperative catastrophe, one of the first things you want to do is turn off the anesthetic, the inhalation anesthetics. Ventilate the patient with 100% oxygen, because so make sure the patient's not hypoxic and being ventilated, turn off the anesthetic, and we did all that, and still the patient is hypotensive. So what could, go ahead, we're listening. All right. All right, this attempt at being interactive is not working, so I'll just keep talking. So we thought we had a heart problem, okay? And how could we evaluate the heart? We could look at the neck veins. And actually, had we looked at the neck veins earlier, we would have found that the neck veins were distended. So if the neck veins distended, that means we've either got heart failure, pericardial tamponade, pulmonary embolus, or a tension pneumothorax. Now we know we don't have a tension pneumothorax because we've already put a chest tube, right? So we could have a massive pulmonary embolus. That's pretty unlikely. And if we've got a massive pulmonary embolus, there's not much we can do about it right now. So it doesn't pay to make that diagnosis. But we're dealing with either heart failure or tamponade. So what we did was we made a small incision in the diaphragm, opened the pericardium, and all this massive bloody fluid came out. So this patient actually had pericardial tamponade. And the reason the patient had pericardial tamponade was that the patient had a retrograde aortic dissection into the pericardial sac. And as soon as we drained the pericardial sac, the blood pressure came up. We made the diagnosis of a retrograde dissection, closed the patient up, sent the patient off to a cardiothoracic surgery service. And to my surprise, they elected not to operate on the patient. They just treated the patient with beta blockers and blood pressure reduction, and she survived and went home. So you can see that this is a very unusual case. The patient presented with abdominal pain. It was misassessed. She probably had back pain radiating, but they thought it was abdominal pain in the emergency room. So the patient presented to us. I didn't see the patient until the patient was in the operating room. I made a decision, which I'm happy that Dr. Mugisha agreed with. I think it was a reasonable decision to take the patient to the operating room, and then we figured it out on the operating table. In other words, instead of having the patient in the X-ray department, this place, that place, and they maybe have an arrest there, we had the patient in the operating room where we could deal with whatever problem we were having. Now, if we would have been smarter, and if we would have been later on, right now, we all have ultrasound machines in the emergency room. We could have put an ultrasound machine and diagnosed tamponade, with the fast exam and take care of it that way. Or if somebody would have looked at the neck veins earlier and seen massive distension, they may have copped to the fact that she would have pericardial tamponade earlier. But anyway, sometimes in the middle of the night, when you're not thinking straight, you're going to have a problem. That's why I presented this case, because it shows you the utility of doing an analysis with this simplified system. Okay, let's keep going. Now, somebody, I forget who it was, mentioned that that we could have a pipe problem due to vasodilatation, due to vasoactive drugs. We talked about anesthetics. We've talked about all inhalation anesthetics cause vasodilatation. The patient may be taking antihypertensive drugs, or the patient could be in septic shock. Now, we considered in this lady septic shock, and before we figured out that she had tamponade, that was still a possible working diagnosis. But she had a normal white count and a normal temperature when she was in the emergency room, and there was no evidence of infection anywhere, and so we thought that septic shock was way down on the list of the differential diagnosis. And then we considered neurogenic shock. She didn't have a spinal or epidural anesthesia, which routinely cause hypotension. We considered maybe she had an unrecognized spinal cord injury, but that was very unlikely. So that's why we focused on the pump and finally diagnosed the tamponade. Now here's another guy. Let's talk about this case. This was a 51-year-old paraplegic man who was struck by a car while crossing the street in his wheelchair. Okay, so this guy had an accident decades before. He's crossing the street. He gets hit by a car. He's thrown through the air 30 feet. Okay, somebody's got some music on, which is very nice, but if you could mute it, that would be great. Now, initially, the guy's vital signs were stable in the emergency room. So he goes through the whole thing. We do a history, physical examination. He gets a CT scan of his head, of his abdomen and chest. Everything's normal. We do films of his axial skeleton, no fractures. Everything's okay. But I tell the residents, look, this guy is in a wheelchair. He's paraplegic. Let's just stick him in the ICU and keep an eye on this guy because he got 30 feet. The mechanism, it was a significant mechanism of injury. So let's put him in the ICU. Okay, so we put him in the ICU. I'm going around doing other things, making rounds, whatever I was doing. I can't remember now. 2 hours later, I get a call from the ICU. The guy's blood pressure is 70 systolic and a heart rate of 120. Okay, Victor Sensa. Okay, please, listen, when I call on you, open up and answer the question so we don't waste time. Okay, if you can. All right, so Victor, what do you want to do with this guy? Paraplegic guy in the ICU for 2 hours, okay. All his studies were normal, and now he's profoundly hypotensive. What do you want to do? Anybody want to answer? Somebody, please. Mugisha, somebody answer.
You can try. Yeah, Justin, go ahead.
This patient is having like two problems. The first one is paraplegic. By the way, it's for a long time. I can think about spinal shock. And then the mechanism of injury seems to be severe. I'll take good IV access. I'll start running fluid as well as the treatment for spinal shock and examine thoroughly the chest and the abdomen. If I can find out another cause, either bleeding or another cause of this shock. Okay. I think there is some visceral injury if it's not the spinal shock injury.
So what do you think the probability of having spinal shock to such a degree is in an old spinal cord injury, like years previously, high or low?
Yeah, I see here the mechanism of injury is very severe. but I'll doubt a little bit about spinal shock because of the heart rate. The heart rate, he could present with bradycardia, but here the heart rate is very high. So likely to be a visceral injury or a bleeding from somewhere.
Okay, so what do you want to do with him?
Then I'll take a large IV access. I'll start running fluid. I'll give a bolus of 2 liters and
All right,
assess.
I'll give you, you know how to do all that. You're resuscitating him. But what,
Yeah.
where do you want to resuscitate him? You want to resuscitate him in the X-ray department, the ICU, the operating room? What do you want to do with him?
This patient is in ICU. If
He's in ICU.
yeah, I'll do.
Look on mute.
Anybody else have any other ideas? All right. Well, I'll tell you what I did.
So,
Go ahead, Mugisha. Go ahead.
yeah, someone said, start resuscitation in the, take the patient back to operating room.
Okay.
And
And
explore-
so
and
the
explore-
person who
and-
said that, why do you want to go to the why do you want to go to the operating room? What's your rationale? What reason do you want to take him to the operating room?
He is thinking probably something was missed in the initial evaluation with the CT scan, and the hypovolemia is giving him troubles.
Okay, so you think the patient may be bleeding? Okay. All right. Well, I had the same thought. So I said, I wasn't there. I was somewhere else. I said, take the patient to the operating room. I'll meet you in the operating room. So we're in the operating room, and the anesthesiologist is resuscitating the patient, doing a great job. And I'm circling the patient, and I'm trying to figure out what the hell is going on here. So I order an AP chest X-ray. I'm circling, feeling the patient's abdomen. Of course, that's not going to be that helpful because the guy's paraplegic, but still I'm looking for distension or swelling or something. Flat as a board. And so I think, well, I'm going to do a diagnostic peritoneal lavage. Okay, so I make a little incision, a little tube in the patient's abdomen. No blood in the peritoneal cavity. The chest X-ray comes back normal. So I'm on my hands and knees trying to figure out what the hell is going on here. And all of a sudden, I see frank pus in the Foley bag. So in other words, we know that paraplegic patients have a high incidence of urosepsis because they're catheterizing themselves or they got indwelling Foley. And in fact, the reason for death in many paraplegic patients is urosepsis. So this guy was thrown 30 feet. I don't know how he got acute urosepsis. He probably had chronic urinary tract infection. For some reason, either the accident or putting a Foley in or whatever it was stirred up a bacteremia from urosepsis. And so once I saw that the guy had frank pus coming out of his tube, we just continued to resuscitate him with fluids and antibiotics, did not operate on him, and took him back to the ICU once we stabilized him in the operating room, with professional anesthesiologists resuscitating him, took him back to the ICU, and he recovered and went home. So this is another example of going back to this thing here. We've got a pump, pipe, and fluid in the pipes. The guy was hypotensive. His heart was working. We couldn't find any source of bleeding. So we figured, well, we must have a pipe problem. And I couldn't figure out where it was. And then all of a sudden, it's dawned on me that the guy had urosepsis, and that's why the pipes were dilated. Everybody got that? All right.
Yes.
All right, let's move on to the next one. And then a fluid problem. Well, on the surgery service, the most common fluid problem we have is hemorrhage. And that's why in the first 2 cases, we decided to take the patient to the operating room when we didn't know what was going on. Turned out in neither of those 2 cases, which were very unusual cases, was the problem of bleeding. but at least we were in a place where we could manage the problem had it been a hemorrhage problem. Okay. Also, obviously, with big burns, you can get you get a leak of plasma and fluid out into the eschar, and with severe pancreatitis and sepsis of any cause. And in fact, with the COVID-19 epidemic, many patients require lots of fluid because of the systemic inflammatory response syndrome. All right. So how are we gonna monitor the shock patient? You guys have all alluded to that. For this talk, this is not a medical student talk on shock. This is a talk for trained surgeons and surgeons in training. About, we're assuming everybody knows how to resuscitate a patient. But in terms of monitoring, we want to put the patient on a continuous blood pressure monitor, or if you've got access to putting an indwelling arterial line, that's great. EKG, pulse oximetry, obviously a Foley catheter to monitor urine output. If you're not sure what the status of the patient is, sometimes we'll get these healthy young guys who are hypovolemic and then in the supine position, they're holding onto their blood pressure. But if you sit them up, you'll notice that their blood pressure drops and the heart rate will go up. The orthostatic vital sign, very useful in fact that if you've got a patient who's NPO all night long, and then you take it to the operating room at 1 o'clock in the afternoon because the case was delayed or something. If you have a good anesthetist, the anesthetist is going to check the blood pressure and pulse lying down, and he's going to crank the table up and recheck it. And if he's got his blood pressure drops, he's going to dump in 500 cc's of fluid or more before he induces anesthesia, because as someone mentioned, anesthetic drugs cause vasodilatation. And of course, you can put a central venous pressure monitor in to monitor the patient. This is an example of a continuous monitoring blood pressure continuously, or putting in an arterial line. And for the treatment, you've obviously got to solve the underlying problem, which means stop bleeding, drain the pericardium, drain pus, and give antibiotics, as we did in these 3 cases, and give blood or fluid, and then monitor the CVP and urine output. Now, when you're assessing the degree of blood loss, well, one way to do it, if it's intraoperatively, you can look at all the lap tapes that are filled with blood, count them, and get an idea of how much blood you've lost, or how much or the blood on the floor. If you've got a big vena cava or aortic injury, you're going to be standing in blood. But another way is a system recommended by the American College of Surgeons, where they classify hemorrhage as class 1 hemorrhage. That is, you lose up to 15% of your volume. That is less than 750 cc's of blood. And in this case, if the patient's awake, the mental status will be normal, blood pressure and pulse will be normal, and urine output will be normal. And this is like going and donating a unit of blood, for example. You go and donate a unit of blood, they give you some orange juice, you lie down for a few minutes, get up, and if you're not lightheaded, you're on your way and go about whatever you're going to do that day. In class 2 hemorrhage, that's loss of up to 20% of the blood volume, or between 750 cc's and 1200 cc's. In this case, the blood pressure may be normal. However, the pulse pressure, that is the difference between the systolic and diastolic pressure, will be decreased. The heart rate will be increased. The patient is often agitated. And if you're measuring urine output, the urine output will go down to 20 to 30 cc's an hour. Of course, when you're looking at the patient initially, you won't have that luxury of looking at the urine output over several hours. But if you're in the post-operative period, you frequently will be able to look at urine output over a period of time. So that's class 2 hemorrhage. Now, class 3 hemorrhage, now here we got a big problem. Here we've lost up to 30% of the blood volume. In other words, up to 1500 cc's of blood. Here our patient is confused, hypotensive, tachycardic, sweating because he's got a sympathetic discharge. And his urine output has dropped below 20 cc's per hour. That's called class 3 hemorrhage. And class 4 hemorrhage occurs. Now here we've got a desperate situation. This guy's got one foot in the grave and another on a banana peel. This guy's about to die. He's unconscious, got no blood pressure, no palpable pulse. He's sweaty, he's anuric, and this guy has lost over 40% of his blood volume, or more than 2 liters. And unless we do something immediately to resuscitate this guy and stop the bleeding, he's going to die. Oops, I'm sorry. All right, so everybody was talking about vascular access before, very good. And I didn't want to emphasize that. At that time, I was sort of making more advanced decisions about where you want to be and what you want to do. But obviously, you're going to put the 2 large bore IVs in, hopefully 14 gauge lines if you're dealing with an adult. If you have a 7 French femoral catheter system available, which is placed by the Sellinger technique, that's fantastic, because you can run blood like soup through this thing if you have it available. Otherwise, put in 2 large bore IV catheters. And if you haven't got large bore IV catheters, you can do a venous cut down and stick a number 8 or a number 10 infant feeding tube down, cut the length, stick it in there, and you can run blood like soup through that too, although it does involve a cut down. One great place to do a cut down is over the medial malleolus. The saphenous vein runs with the saphenous nerve. It's just anterior to the medial malleolus. So if you make a transverse incision over the medial malleolus, put a Kelly clamp down on top of the medial malleolus, come up and you lift up, and the vein will come up with the saphenous nerve. Just take a moment and separate the saphenous nerve from the vein. You can tie the vein off distally, make a little incision, and as I mentioned, put a number 8 or number 10 infant feeding tube, cut short, maybe about 5 or 6 inches, no longer. Because remember, the longer the tube, the higher the resistance to flow. So we want to keep this tube relatively short so that we have a low resistance to flow. Now, you can also put an interosseous needle in. I have very little personal experience with interosseous needles, but I am told by my younger friends who use them that this works. You put the needle in. There are 3 places you can put it. You can put it in the just below the tibial plateau on that broad flat area of the tibia. You can put it into the femur through the quadriceps femoris, or you can put it put it into the sternum. I don't like putting it into the sternum because the heart's right underneath there, and I just don't like sticking sharp things in the region of the heart. But certainly into the femur or into the tibial plateau is a great place to put it, and you aspirate, get blood or marrow back, and then you can start your infusions there. And does anybody, let me stop here. Does anybody in the group have personal experience using the interosseous needle?
Yes, I've used it in children. You need to have a gun.
Why don't you tell us about your experience?
So you have to identify the most probable area where you can put your intraosseous needle, and preferably it is the tibia. Many times you palpate the tibia tubercle and you come down 10 or 15 centimeters below, or 5 to 10 centimeters below the pubic tubercle. Just perpendicular to it, you need to fire the gun, and the gun has got 2 parts. Has got the handle whereby it can you can punch it, and you have a needle that will go through. You can make a small nick on the skin to avoid the skin barrier, so that you can be straight to the bone, and you punch it. The moment you finish putting it, you remove the stellate in the middle, and you connect the IV fluids. But it should be noted that this is a very limited, short time, as you are looking for long time IV access, whether through central or through IV cut down. So that's my experience. It tends to block, and the fluid does not flow at a speed and at a rate that is required. That's why it is preferably in children where you need a small amount of volume of fluid.
So, well, thank you very much, Mugisha. That it was originally developed for children, but in military situations, you can also use it in adults. As I said, I don't have any personal experience, but thank you for sharing your experience, Mugisha.
Yes, and another colleague have written in the chat box that for adults, the tibia doesn't work. You have to go either to the femur or to the pelvis.
Okay, thank you very much. All right, so central venous access is you can either do it with the subclavian or the internal jugular. I had to forbid subclavian venous catheterization in the emergency room when I was the chief of surgery because we had a lot of complications in empty patients. In other words, if the subclavian vein is collapsed, it's easy to get that needle in the subclavian artery or cause a pneumothorax. I prefer in a patient in shock who's empty to use the internal jugular vein, venous access because I think it's a lot safer. If you get into the carotid artery, it's not that big a deal. You can just hold pressure. Whereas if you get into the subclavian artery, it's very difficult to tamponade. And I have seen a couple of patients exsanguinate from inadvertent injury to the subclavian artery during subclavian catheterization. So just be aware of that. I would, if you want to do subclavian catheterization, I think it's acceptable. If you've got both of these catheterizations should be done with ultrasound guidance. And I think if we're using ultrasound guidance, it's a lot safer than when we were doing them blind, which was going on for decades before bedside ultrasonography became, the technology became available. So it's a lot safer now than it used to be. So let's move on. So we talked about resuscitation. Everybody, when I presented those cases, everybody says, well, I'm going to resuscitate the patient. And I sort of cut you guys off a little bit about that because I wanted to get on about the decision about where are you making. So let's go back to resuscitation. First of all, what does it mean to resuscitate somebody? Well, we could, sometimes we resuscitating a specific organ, resuscitating the heart. Sometimes there's brain resuscitation, although I think that's very difficult to do in a resource limited environment. Or we're resuscitating the kidney, trying to get the kidney to make urine. Or that's one type of resuscitation. Or more generally, we're trying to do whole organism resuscitation. In other words, we're trying to restore blood flow to all the vascular beds, the heart, the brain, the splanchnic bed, which includes the kidneys, the liver, the intestines, and the extremities. So I don't know how many of you have ever seen dopamine feet, where you've got gangrene of the toes and the fingers because the patient was in profound shock and was on such high levels of vasopressors to keep the patient alive that there was no blood flow going to the extremity, to the fingers and the toes, and they died. I remember the one case that I saw was a case of meningococcemia, where we were struggling with the patient for days. The patient ended up surviving. We actually had to do bilateral below-knee amputations because of gangrene of both feet, because of vasoconstriction. So how do we know when how do we know when our patient is resuscitated? Well, there are certain clinical endpoints. If the mental status improves, if the blood pressure improves, the pulse improves, or the patient starts making urine, okay, well, we're in great shape. We've got those are our clinical endpoints. But these clinical endpoints are pretty gross. So then we have physiologic endpoints, which we could use. And the one that's going to be most available to you are central venous pressure catheter, because that can give you an assessment of venous filling. So obviously, if the patient is in shock and the CVP is 0, and you resuscitate the patient, now the CVP is 10, that's physiologic evidence that you restored intravascular volume. In the past, in the high-income countries, there was a wide spread use of pulmonary capillary wedge pressures. We now use them much less because it didn't really affect outcome in most cases, unless you're dealing with a heart failure patient. We can actually measure cardiac output. And I won't go into some of these other advanced methods for tissue oxygen probes and cerebral perfusion pressure and all that, but just say that what we're talking about in most of the hospitals that you and I are working with in Africa is central venous pressure measurement, because that can be done. And then there are, of course, global biochemical endpoints. In other words, if our patient is acidotic, there's a low pH, a high lactate level, a high base deficit level, that's indication of aerobic respiration. And if the pH, the acid base status improves with resuscitation, that's evidence that we are moving in the right direction in terms of resuscitation. But we have clinical endpoints, we have physiologic endpoints, and we have biochemical endpoints. So in summary, the goal of treatment of shock is restoration of oxygen delivery to the tissues. Most patients on the surgical service who are in shock are bleeding after injury. The overwhelming majority of the rest of them have systemic inflammatory response syndrome. Now, if your patient is bleeding, the key determinant of survival is the time between the onset of bleeding and the cessation of bleeding. So, for example, ladies and gentlemen, if you have a patient who's in the emergency room who's bleeding, let's say he has a ruptured spleen, and you're not, and the spleen is really right, you've decided the guy needs an operation, not non-operative treatment. The whole treatment of ruptured spleens, that's a whole separate topic. But let's just say the guy is bleeding to death. And so the idea is not resuscitate the patient in the emergency room, blah, 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 until the operating room becomes available. No, your job is to get that patient into the operating room. And I can tell you right now, somebody's going to tell you there's no room. We don't have an anesthetist. We don't have this. We don't have that. You can't, the patient's life is in your hands. If you're a resident and you're taking care of that patient, if you don't make something happen, that guy is going to die. He's going to bleed to death. So you have to, with a smile on your face, just show up. And it's never happened to me that I brought a patient to the operating room that an operating room magically became available. I don't care if you have to operate on the guy in the hall. Just the guy needs to be in a place where you can stop the bleeding. The longer the patient is bleeding, the less likely he is to survive. And then remember the simple schema of pumps, pipes, and fluid in the pipes to sort out unusual causes of hypotension. I told you that most patients are either bleeding or they have the systemic inflammatory response syndrome, but not all of them. And you have to think a little bit, go through this thing. Is he bleeding? Now, if the guy's got a gunshot wound to the abdomen, and he's in shock, the guy needs to be in the operating room. You don't have to think too much about that, okay? But if we have a patient like the patient with who was in the emergency room for 6 hours and suddenly dropped their pressure and ended up having pericardial tamponade, well, it would have been better had we sorted that out before going to the operating room, so we knew what we were going to do. But even if you make an error in judgment or an error in diagnosis, you at least want to be able to go through the process of thinking it out and extricating yourself from the wrong path. Okay, so now we're going to go through a series of cases, and Mugisha, I want you to I'll present it very quickly, and then I want you to lead the discussion, calling on people to answer. So we try to get some interaction, try to get you guys to think through these problems. And remember, there's no reason to be embarrassed or anything. There's no wrong answer. Any answer is reasonable as long as you can defend your decision and give a reason for it. So here's the first case. You got a 33-year-old guy who has come to after an automobile accident. He had an acute abdomen, hypotensive in the emergency room. You take him to the operating room. He has a ruptured spleen. You take the spleen out, easy case, close him up. He goes to the recovery room. In the recovery room, when you arrive in the recovery room, the first blood pressure reading is 70/40 and the heart rate's 130. So why don't you guys have a discussion with the management? Mugisha, why don't you lead the discussion? I'll answer any questions that you have.
Well, thank you very much. And any answers from the chat box or from the audience? You feel free, just unmute and answer the question. What will be your way forward? The patient is in a recovery room, has not left the operating room. Yes, Alex? Bahati? What will be your approach? Justin?
I think the best idea is to go back to the operating room, resuscitate him when they reopen and see. Probably there are some loose sutures which have given away and the patient is bleeding again.
Okay, thank you. Justin, I can see you unmuted.
Yeah, I would like to know, upon finishing the operation, what was the blood pressure just when we finish the operation?
110/80.
Now you have the
Yeah,
answer.
so,
Go ahead.
yeah. So this patient seems that he's bleeding. I'll assess him. I'll check the abdomen. Is the abdomen distended?
It's hard to say because he's an immediate post-operative abdomen. It's not obvious. It's not massively distended. He's tachycardic and hypotensive. 15 minutes after the operation ended, 20 minutes after the operation ended.
I think I'll take back also the patient in the OR and I'll open the abdomen. Since he started bleeding, there is a vessel which is bleeding in.
Okay. Well, it's a little
So
embarrassing. It's a little
from the chat
embarrassing, don't you
box?
think? It's a little embarrassing. You're getting to the operating room and then you're gonna have to turn right around and go back and all the nurses are looking at you. You're still gonna take them back?
Yeah, so there is a person from chat box that he will do an advanced life support assessment, A, B, C, D, E, and treat adequately. That's from chat box.
Okay.
So that he can really come to a diagnosis, most probable diagnosis and management appropriately.
All right, so always good to check the ABC, and that can be done in 2 minutes. Airway's okay, patient's pulse oximetry is normal, he's breathing normally, and C is a problem. He's hypotensive and tachycardic.
Daniel?
D is difficult to assess because he's just emerging from anesthesia. And
perhaps you take the anesthetic because most of the anesthetic drugs have a tendency
well, I agreed with the first two speakers. The first two people who answered, even though it's embarrassing, I just said, sorry, we must have a problem. We made a 180-degree turn, went back to the operating room. You know, I had my tail between my legs. My anesthesia friends reintubated the patient, opened them up, and there's a little blood vessel underneath the xiphoid that frequently is a problem, and the patient was actually bleeding. The splenic bed looked fine, the peritoneal cavity looked fine, but he was bleeding from this little pumper underneath the xiphoid. So we put one stitch in it, washed them out, closed them back up again, went back, and everything was all right. So the point of this is this was a very simple case, a simple problem, and you guys made a very good decision to go back immediately. But the point is that you're always trying to think when you have a complication, there's a tendency to say, well, this can't be happening to me. It's like being an ostrich and sticking your head in the hole in the ground. you don't have to look around. You just have to face up to what's happened and deal with it. So I made a mistake when I closed. I missed that little bleeder underneath the xiphoid. We went back, put a stitch in it, and took care of the problem. Rather than being in the recovery room, transfusing the patient, trying to, trying to have and then go back 3 or 4 hours later after you've given the patient 4 or 5 units of blood. Okay, let's go to the next case. Let's go to something a little more difficult. Okay, now this was a 65-year-old woman who underwent a low anterior resection for a rectal carcinoma. The case went beautifully. We had clear margins. This was a curative resection. In the recovery room, the blood pressure is 170, and systolic, and the heart rate is 130. So we followed the advice of the 2 previous speakers, and we went back to the operating room and opened the abdomen, and there was no evidence of hemorrhage or anastomotic leak, and I couldn't figure out what the problem was. So what I did is I did a proximal diverting colostomy because I was worried about the integrity of the anastomosis because she was in shock. Closed her up, and she's back in the recovery room, still in shock. Mugisha, why don't you lead a discussion? What are you going to do about this situation?
Right, Braveheart.
I have to say that I did not distinguish myself on this case.
It's okay. Daharan, you can just unmute yourself and give some comments. Catherine, Lukiza, Edward, who is ready?
Guys, this is not rocket science. You don't need to think for a long period of time. Just answer, say something. If you're not interacting, the whole thing is not going to work.
Let's hear from Smart 5. Okay, Smart.
Okay. 65-year-old woman, being a woman, being elderly, and pelvic surgery, there is a high risk of having this hypercoagulability state. So pulmonary embolism could be one of the reasons.
Okay, so you're worried about pulmonary embolism. How could you diagnose a postoperative pulmonary embolism?
Daniel, go ahead. How can you diagnose pulmonary embolism?
Maybe we could do the ECG.
And what would you expect to see on an ECG? In other words, if you do an electrocardiogram, what findings would you expect to see on an EKG? You know, if you don't know, just say I don't know.
I've forgotten.
Okay, so an EKG is one method of diagnosing the pulmonary embolism. It's not a particularly good method, but what you will see with a massive pulmonary embolism is a right axis shift. You will also see flattening of the P wave. And the reason, and these are EKG evidences of acute pulmonary hypertension. So basically, the physiology of a massive pulmonary embolus is acute pulmonary hypertension, and the EKG evidence is a right axis shift and flattening of the P wave. Are there any other things that you could do to diagnose a pulmonary embolism in addition to an EKG?
Okay, yeah. So we still have a case on board. What will you do? Smart 5, your microphone, I think, is not working properly, or you are missing something. Please check it.
Okay, well, sounds like nobody's answering the question. So
there's someone.
Somebody wants to
in
answer the question?
box.
Okay, go ahead.
Yeah, he's saying we do a sepsis wake-up and consider starting vasopressors.
All right, so we start vasopressors. We're doing blood gases. We still want to rule out a PE. What other findings would you, on physical findings, would you look for an acute pulmonary embolus? Well, you look for you look for distended neck veins. Would be a sign of acute pulmonary hypertension. If you put your hand on the chest, you might feel the right ventricle pumping to excess, trying to get that blood past the pulmonary embolus. But really, the best test for pulmonary embolus is a CT angiogram, which is a very, very accurate test for pulmonary embolus. You could also do sometimes you can make the diagnosis with esophageal echo, but the best test in 2021 is a CT angiogram.
CT angiogram.
Yes,
I
but
agree.
however, what's the chance of having an acute pulmonary embolus right after surgery? Could happen, but it's probably low. Okay.
Yes, it is low.
If I looked at the neck veins and the neck veins were distended, what other diagnosis should I consider?
You should consider pericardio bleeding or cardiac
Right.
tamponade.
Right, we could have tamponade, or we could have a heart failure from an MI or something like that. So we did the EKG as was suggested. There's no evidence of an acute MI. We're getting troponin levels, we're getting blood gases, all that sort of stuff. However, if we did an ultrasound examination of the heart in this patient, which we did, but unfortunately I didn't do it for 6 or 7 hours. The patient had pericardial tamponade as a complication from a CVP line that was placed unnecessarily by the anesthetist intraoperatively without telling me, and I wasn't even aware that it was in, and he didn't do a good job, perforated the right atrium, and the patient had tamponade. We drained the tamponade, the blood pressure improved, but unfortunately, after 4 weeks, the patients died of multiple organ failure. And first of all, the CVP line was unnecessary since we weren't having any problem intraoperatively. And I made a mistake in failing to look at the neck veins early on and getting an ultrasound to rule out a heart problem. So this was a terrible tragedy because this woman had a curative operation who died from an iatrogenic complication that was unnecessary. So that's case number 2. Let's see how you guys do on case number 3. All right, now this happened many years ago. This happened when I was a resident. I was a senior resident on the cardiac surgery service, and I happened to be in the ICU when a 45-year-old woman arrives in the ICU in shock after a total abdominal hysterectomy for benign disease. Now, this is not my service. I'm just standing around picking my nose, taking care of my own patients. This had nothing to do with me, but I looked at this woman, and the gynecologist comes in and he tells that this patient developed DIC during the operation, and there's no surgical bleeding, all right? And the patient's in profound shock. Okay, let's Mugisha, why don't you lead the discussion, what you're gonna do? Anybody have a suggestion? What do they want to do?
Yes, Infinix is raising a hand. They wanted to comment, but I don't know what is happening. We can't hear you. We can't hear you. We can't hear you. Someone else?
Can somebody
I
add?
really wish you can check with your microphone or your setup there so that we can be able to understand what you're saying.
Okay, a very simple problem. 45-year-old woman after an abdominal hysterectomy for benign disease. The gynecologist said the patient has DIC, she's bleeding, the patient's in shock. What do you want to do? This is not nuclear physics, guys. This somebody answer the question.
From the chat box, go back into the operating room.
Okay, well, the gynecologist is saying, well, right now the blood pressure is 50. gynecologist is saying that he's not, has DIC. You're a resident. Hmm. All right. Well, what I did is I put 2 venous cut downs in. This is decades ago, before all the advanced catheter technology. So I just put 2 venous cut downs in, started pumping fluid and the blood into her, and her blood pressure came up. And I just told, and here I am, this young resident. I just told the guy, I said, look, I said, this patient has surgical bleeding until proven otherwise. She needs to be back in the operating room. Another gynecology attending arrived, agreed with me, and they took the patient back. And what she had was, the vaginal cuff on the hysterectomy is a very, very vascular area. And there was 1 pumper there, and 2 stitches solved the problem. And she stabilized hemodynamically, and everything was okay. Very similar to the first case where we were bleeding from underneath the xiphoid. So the point is, you can invent all sorts of reasons for bleeding, but you got to exclude surgical bleeding. That happens. Okay, so we move on to the next case. This is a case from Africa. This was a 23-year-old woman who had this giant adrenal carcinoma on the right adrenal gland. And we did a right thoracolapparotomy, did an en bloc resection of the right kidney, the right adrenal gland, and the right lobe of the liver. And we took out a piece of the diaphragm because the tumor was into the diaphragm. We closed the diaphragm up. She's bone dry when we left, closed her up. 4 hours later in the ICU, she's in shock. We left her intubated because of the magnitude of the operation. We wanted to control her airway overnight. That was a good move because she developed profound hemodynamic instability. Okay, somebody want to discuss the management of this? Here's a young girl, blood pressure is 50 to 60, heart rate's 130, 4 hours after this big operation. Dr. Mugisha, you want to lead the discussion on that?
Anyone who is ready to answer? So was there any tube in the, this one was a question saying, was there a tube in the chest?
Yes, there's we put a chest tube in, there's no blood coming out of the chest.
Okay, just unmute.
So like you said, napenda kutaarifu kuwa tarehe tulikutana because you were in that meeting, correct?
I'm sorry, I couldn't quite hear. Did you hear that?
No, I didn't hear him. Dr. Mpoki, you wanted to make a comment? Did you? Any other person who want to make a comment?
Okay, guys, it's 10 o'clock at night. You got a 23-year-old woman dying in the ICU. What do you want to do?
Someone said reassess the patient with ABCDE. I think that is obvious.
And we've done all that. We've done all that, and the blood pressure is still the same.
I think this patient, after an extensive surgery and the BP is very low, I'll take back this patient in OR. I'll open the abdomen, make sure that there is no bleeding because the chest tube is not draining anything. That means probably is bleeding from the abdomen.
Okay, I like your idea. That's exactly what we did. We took her back to the operating room. We opened her up. There's absolutely no blood in the abdomen. So I did an exploratory laparotomy. I figured, well, maybe she's got intestinal ischemia, or maybe there was a volvulus. We didn't, when we closed, the intestine got twisted or something. everything was stone cold normal, and we closed her up.
And
that was
if everything was normal after doing nephrectomy and the adrenal gland, probably we are having problem with corticoid. I can give hydrocortisone or to see if I can improve the BP.
Go to the head of the class. You're a genius. You were actually a lot smarter than I was. We took her back to the thing, and I couldn't figure out what was going on. We did we checked the heart. The heart was fine, and I'm in the shower 15 minutes later, and it didn't hit me till I was in the shower. I said, "My God, you must have adrenal insufficiency." So we gave her some cortisone, and her blood pressure came up, the heart rate went down, and she was able to go home. So, who was the guy that gave that answer?
guys, Justin.
That was a fantastic response, and so the reason I'm presenting this case is for everybody. Always remember that acute adrenal insufficiency is very rare, but it's totally correctable. And if you miss it, the patient can die. I can remember a friend of mine who was one of the world's experts on the adrenal gland missed post-operative acute adrenal insufficiency, and his patient died. And this guy was this guy I have tremendous respect for. He's a great surgeon, a great thinker, but we all make mistakes. So you want to learn from his mistake, learn from this case that acute adrenal insufficiency is an unusual cause of shock, but it's totally and completely correctable with cortisone, hydrocortisone. Any other comment? Anybody else want to make a comment? All right, let's move on to the next case. Okay, you're helping a colleague with a very difficult abdominal perineal resection for a very large adenocarcinoma of the rectum. And you're in the middle, you're doing the perineal section, and you look up and you ask the anesthetist, how's the patient doing? What's the blood pressure? And he casually reports that the patient has a systolic blood pressure of 50. Okay. Mugisha, why don't you lead the discussion? What are you going to do now? Patient's legs are up in stirrups, the belly's open, you're halfway through the perineal dissection, and you're just checking on it. You've got to maintain verbal contact with the anesthesia team at all times. They've got to know what you're doing. You've got to know what they're doing. And so I just in that light, I just say, how's the patient doing? What's the patient's blood pressure? Oh, the patient's blood pressure is 50. What do you want to do?
So stop the surgery and look for the bleeders.
Okay, so we stopped the surgery. I mean, the patient was oozing a little bit, but it wasn't anything dramatic. But you're right, we stopped the surgery and I packed the pelvis with a whole bunch of packs, and the blood pressure comes up to 70 to 80 with fluid resuscitation. The anesthetist was not a particularly strong anesthetist. He had under-resuscitated the patient. And so then I said, well, have you given the patient any blood? So he says, no. So then I said, well, where's the blood? And the answer was, there was no blood in the room. I said, well, who's going to get the blood? We had all these people in the operating room, and everybody's standing there with their mouth open. Okay, so nobody's going to get the blood. So what are you going to do? This I didn't make this up. This really happened, and my guess is it happens on a regular basis. So what are you going to do? You got a patient who's hemodynamically unstable in the middle of a big life-threatening operation, and nobody's going to get the blood. Has anybody seen that before in their hospital?
I haven't encountered one. Anatoly? Yes, Justin, go ahead.
I think I'll ask which type of anesthesia. If they are using gaze, I'll ask them if it's like isoflurane to close to see if we can improve the BP. I think that the problem can be of vasodilatation due to the gas we are using.
Okay, well, I like that. I always like the concept if you're having an intraoperative problem, shut off the inhalation anesthetic. That's a fantastic response. However, there's lots of, I mean, we probably had lost a couple of units of blood by this time. This is
Yes.
a big operation.
So I think is to do minimal, stop the bleeding, and postpone the procedure until when you are able to get enough blood products.
We can't postpone the procedure. We got to finish the procedure. We're halfway through a perineal dissection. All right.
Right.
So what we did is this. Remember, guys, I told you that the patient is a football. You got to get the football across the goal line, and there are all sorts of people on the opposite team blocking you. Okay, so in this case, I said, okay. I looked at the guy I was helping with, the surgeon, and I said, I'm going to stay here with the patient and hold with the packs. You go get the blood. So I sent the chief surgeon went to get the blood. Why did the chief surgeon get the blood? Because at that moment, that was the most important thing that could be done during the operation. Otherwise, the patient's going to die. You understand what I'm saying? So he went and got the blood, and it's a good that he went and got the blood, because the blood bank technician is having a cigarette, and he says, I can't get the blood now. I'm on my break. Well, I, as a visitor, I don't know how to make the hospital work, because that's not where I work usually. But this guy worked there, and he looked at him and he says, well, if you don't go and get the blood right now, I'm going to call your supervisor. And of course, then he went and got the blood. We transfused the patient. We finished the operation. Everything was fine. Patient survived and went home. But my point is, you have to look at, when you do it, you have to look at what's the key thing that's happening at this moment. And at that moment, the key thing was we need to have blood in the operating room. Now, should that have happened? No, somebody should have went and got the blood. I got the blood, but it wasn't happening. So we stopped the operation as Dr. Mugisha recommended. We shut off the anesthesia, as whoever made that very astute comment made. And then we sent somebody with moxie, somebody with power to go get the blood. Otherwise, it wasn't going to happen. All right.
Okay.
Somebody doesn't have their microphone on mute.
Let me check. It's only me and you.
Okay, so now let's do the next case, guys. All right, here's an interesting case. Can you guys hear me? This was I'm in the operating room doing I forget what, some case, and then there was another team in another operating room that was having trouble. They were operating on a 17-year-old girl with a huge pancreatic mass that was stuck to the portal, splenic, and inferior mesenteric veins. The patient had already lost a lot of blood. But you come in there and you assess the patient. How many people, it's stuck to the portal, splenic, and inferior mesenteric veins. How many people want to stop the operation? Because this is an unresectable pancreatic cancer. Mugisha, lead the discussion. Anybody want to stop the operation?
Yeah, so there's someone say stop the operation in the chat box.
And what's your reason for stopping the operation?
Again, let me check the chat box. But I think I agree, you should stop the operation. No, yes. You need resuscitation. Because the patient needs resuscitation.
She's got a stable blood pressure right now.
So you have the tumor that is involving is unresectable tumor.
Okay, good. Okay, so right. So you want to stop the operation because it's unresectable. That's exactly what I thought. I went in there, scrubbed in, and I said, "Boys, I think this is not resectable." So then I'm going. So I'm sitting down having tea, and I'm thinking, why should a 17-year-old girl have an unresectable pancreatic carcinoma? And then the light bulb went on. I said, shit, this must be a neuroendocrine tumor. This is not pancreatic cancer. And so I've come back. They already closed, had the fascia closed. And I said, you know, guys, let's take the stitches out and take another look at that thing. So I look at it and I say, well, let's see if we can get this thing out. So, but by this time, her blood pressure was stable, things were good. So, in dissecting the thing off, we got a little hole into the junction of the splenic vein and the portal vein. So I closed it up, but of course we had lost a fair amount of blood. And I said, well, how much blood have you given? And the guy tells me, well, we haven't given any blood. Well, I said, well, where's the blood? And there was no blood that had been ordered. So this was my fault. I couldn't imagine that these guys were going to do this case without ordering blood, but that's what they did. So now we've got a patient with no blood, and we're sort of halfway through the removal of this tumor in the belly, but we can't operate, as has been explained. So what we did is we packed the abdomen, closed the skin, not the fascia, just closed the skin with Paxil, and took the patient to the ICU intubated. And I looked at the resident and I said, I don't care how you do it, but the most important thing you can do tonight is get blood for this girl, because tomorrow we have to take her back, resuscitate her and take her back and finish this operation. So the guy who saved the patient's life was the resident, who somehow didn't accept no for an answer, and during the night was able to get 3 units of blood for her. We transfused her up, went back, got the vessels off the tumor, and did a distal pancreatectomy. She went home. She survived, and I don't have long-term follow-up on her, but she was alive 6 months later, you know, at home, doing reasonably well. Now, whether this was a malignant or a benign neuroendocrine tumor, I don't know. Hopefully it was benign, and hopefully we cured her, but at least we gave her more time, if nothing else. So I want to, with this case, I want to introduce to you the concept of damage control laparotomy. And we usually are doing this in trauma, where we have a massive injuries, where we need to maybe do bowel resections and all sorts of stuff. But in addition, the patient's bleeding. Let's say the patient has a vena cava injury and a portal vein injury and multiple holes in the small bowel for gunshot wound. So damage control would be stopping the bleeding, resecting the bowel, but not doing the anastomosis, not spending a lot of time in the operating room. Make sure that there's no holes, so you're not leaking succus, doing the vascular repair, close the skin, ventilate the patient overnight, resuscitate the patient, get blood, warm the patient up. Then in the morning, when the patient's stable, you can go back to the operating room, take the stitches out, complete the intestinal reconstruction or whatever else you have to do, and then do a definitive closure. So that's concept of damage control and trauma. In this case, this was an elective case where we had basically a situation where we had an empty patient with no blood. And so we just had to, stop the bleeding, close her up, and ventilate her overnight, and then get the blood and go back the next day. All right, well, that completes the unknown cases for you guys. And I'd like to, we have about a few minutes left. If anybody wants to make any comments or discussions, and then we'll end our meeting. I want to thank everybody for attending, by the way.
Yeah, thank you very much, Prof. I would like to make one comment. I think it is very important to anticipate the shock even before when you go to operation. Good preparation will tend to prevent shock or give you adequate management, early management into shock management. We have a couple of patients who are in impending shock and they're about to go for surgery. And when you don't do adequate plans, you may find yourself into the problems when you have bleeding, complicating other impending shocks, like the patient who has peritonitis even before surgery. You are going to drain the pus in that peritoneal cavity. You have to anticipate the chances that he can develop a shock postoperatively in the or immediate after surgery. When you have that in back in your mind, you are able to prepare and you are able to be having enough preparation that will enable you to have a good operation. It is a very valuable concept, and we thank you so much.
Any other comments or questions? Okay, well, hearing no other comments, I think we can end our session this week, and then we'll see you guys again next week.
Yes, I would like to extend our sincere thanks to all those who have attended this meeting for today, and we are looking forward for another talk next Thursday. I would like to take this opportunity to thank all senior colleagues who were in the meeting and those junior colleagues who were in the meeting, and all of us for participating in this wonderful talk that happens more often with our patients during perioperative period. We want to thank all people from different parts, including Ambassador Mpoki, who is known to be anesthesiologist. He was in the meeting and they followed it all. Thank you for coming. If you can salute people, if you're in position, it's okay.
Mugisha, I'm privileged to be part to the great team because surgeons don't work in the absence of anesthesiologists. It's a privilege to hear their thinking and the strategies that they have in caring for the sick, the interest in the patient. And when we work together with the understanding to the direction that the surgeon is taking, the preparations, the implementation, the end results will always be good. And all of us will be happy with good surgical results when patients get out of the operating theater instead of leaving them on the table. Yeah. Thank you so much. God bless you all.
Yeah, I think you're making a very important point that communication between the anesthesiologist and the surgeon is absolutely critical. And really, we have these artificial barriers between nursing, anesthesiology, surgery, and what we really need to do is break down those barriers and just understand that we're all on the same team, working for the good of the patient. And many errors occur because of poor communication.
Thank you very much, Dr. Bill, for your wonderful time. We know you must have been resting now, but you still extended the time to really improve our understanding that will eventually improve quality of care to our patients who underwent surgeries. We are looking forward for another talk next Thursday, and we are all welcome. Thank you, everyone. If you're interested to get the materials and the recordings for this meeting, please email me or WhatsApp me on the advert, on the number and the email that are indicated on the advert. On behalf of NetCare Foundation and Alliance for Global Clinical Training, we thank all of you. Thank you so much, and that marks the end of our meeting.
Okay, bye-bye, everybody, and thank you. Have a good evening.
Thank you.
Thank you, Professor.